a number. We're thinking about volume. We're thinking about strength of contractility. But again, this is very subjective. Someone might feel a pulse and say, oh, it's very weak. And someone else can say, oh, I can feel it fine. But we know that many factors can affect the pulse. The patient's age, medication the patient is on, existing medical conditions, or even symptoms that the patient presents with, like a fever, and obviously the fluid status. So what exactly do we monitor in the ICU to tell us more about the patient's pulse? Well, quite a lot of things, but one of them is the ECG. Now, the ECG detects the electrical activity of the heart, as you all as anesthetists know. And arrhythmias are very common in the ICU. At least 40% of patients in the ICU will have an arrhythmia at some point. So you need to be monitoring the ECG of the patient. What are the things that can cause arrhythmias? Anything, really. Electrolyte imbalances, metabolic disturbances, invasive lines, multiple drugs, and changes in intravascular volumes. These things can affect the patient's ECG. Now, sometimes you would have patients who you're treating for a coronary event. For patients like that, you should actually be monitoring the ST segment, and you can monitor that on your monitor. And you will see that ST segment changes will flash up on the top right corner. Please don't ignore that. So let's talk about blood pressure. Everybody knows about blood pressure. It's not only monitored in the ICU, it's monitored everywhere from the outpatient department to, even ENT doctors, I'm sure, monitor blood pressure. And so it's ubiquitous. Everybody knows about it. And there are different ways of monitoring the blood pressure. But in the ICU, you either monitor it invasively or non-invasively. Now, for your more stable patients, you can get away with non-invasive blood pressure monitoring. But for the very unstable, critically ill patients who are on inotropes and vasopressors, such patients, you need to be able to monitor beat-to-beat variability of the blood pressure. And so it's important to monitor with the invasive blood pressure. Of course, we do that using an arterial line. We prefer to use the radial artery. We could use the brachial artery or the femoral. Remember that your saline bag has to be under pressure, 300 millimeters of mercury for that. And remember also that if you do not have a proper tracing, the absolute value you see cannot be trusted, because your trace might be overdamped or underdamped. You have to be sure that you have a dichotic notch, a clear dichotic notch, to believe that this is indeed a normal tracing. Remember also that the reason why we have to check that is because we want to know that the value that we're looking at can be trusted. Now, looking at your wave, you can see that this area, the systolic uptake, can tell us a bit more about the patient's cardiac output. And the dichotic limb, the descent, can tell you a bit more about peripheral resistance. Now, looking at that tracing, you can detect the patient's pulse pressure. So you talk about the systolic pressure, the diastolic pressure, the mean arterial pressure, but you'd also look at the patient's pulse pressure, which is basically the difference between the systolic and the diastolic. For patients who have a wide pulse pressure, it can be physiologic or pathologic. Don't forget patients who have atherosclerosis, patients who have hyperdynamic states, they can have a wide pulse pressure. Patients who have a narrow pulse pressure are typically patients who have cardiac issues. So congestive heart failure, pericarditis, pericardial effusion, you will expect that such patients would have a narrow pulse pressure. Respiratory rate is probably the most underutilized vital sign in history. I know if I asked everyone to raise their hands if they've ever examined a patient but not actually counted the respiratory rate, all hands will be up, I'm sure. Mine inclusive. But respiratory rate is a vital sign which is essential. It doesn't just tell us about respiration, no. It tells us a lot more. It shows us the homeostatic control of the patient. How well is this patient able to keep himself together? That's really what the respiratory rate tells us. And it should never be overlooked. We really need to stop and remember to count the respiratory rate when we're assessing acutely ill patients anywhere, not just the ICU. It is an early indicator of hypoxia. Respiratory rate is more sensitive than you can imagine when it comes to respiratory issues, hypoxia, hypercapnia, metabolic, and respiratory acidosis. Prater's own in 2008 showed that it is a strong forecaster of events like cardiac arrest. And we do know that when we look at it, when we count the respiratory rate, we're better able to detect patients who are about to deteriorate. It can be monitored continuously using a multi-parameter monitor or intermittently by observing and counting manually. The thing about the monitors, though, is that when you're looking at the absolute values you see on your monitor, it depends on how that value is being obtained by that particular monitor. Some monitors use thoracic impedance, which is not very accurate. Okay? Now, for ventilated patients, obviously you can look on the ventilator and you can see what the respiratory rate, you can see what your set rate is. For example, on this machine, the set rate is 16, but the patient's total respiratory rate is 28. It's quite annoying that different ventilators do different things, but some ventilators will have F, which is frequency, or some others would have RR, which is respiratory rate. It does, either one is talking about the respiratory rate of the patient. Now, as I said, if you're using thoracic impedance, remember it all depends on the leads that you put on. So sometimes there can be, faulty readings, and you have to check manually and just to confirm. And also you can use capnography. Capnography is more accurate and gives you a better reading for the respiratory rate. But also there are pulse oximeter waveforms now, like that you can use to determine the respiratory rate. Some monitors, even in use now, have that technology on them, and they are a lot more accurate than using thoracic impedance. Ooh, temperature. Now, temperature, like we've just said, is one of the vital signs we need to monitor according to the NICE guidelines. It's very important to monitor closely because we need to be able to manipulate. We don't want a patient to be hyperthermic. It's not good for the brain. It's not good for complete metabolism of the patient. Hypothermia as well. It's not good for wound healing. It's not good for the patient's brain as well. So we really need to be able to monitor the patient's temperature closely. Because there are physiological and biochemical ill effects of extremes of temperature. Ideally, we should be monitoring core temperature. So core temperature can be monitored either using the brain, intravascularly, or the urinary bladder. But obviously, we're going to weigh the pros and the cons. Why would we want to put a probe in the patient's brain just to monitor temperature when we know that there are increased risks of infection you doing that? So typically in our ICUs, I know lots of us use the auxiliary probe, but that's doesn't actually give us the patient's core temperature. So we could either use a urinary probe, a nasopharyngeal probe, or an esophageal probe to give us more accurate readings. But obviously, something is better than nothing. If you don't have those, use the auxiliary one. And like I said, the trends are more important than absolute value. So you're not just looking at what the temperature is now, but you're checking continuously to see how is it trending. Oxygen saturation. Everybody knows about oxygen saturation now, thanks to COVID. My mom has has a pulse oximeter in her home, so that's to show you the level of that. But and I'm sure as anesthetists, we all know about oxygen saturation. We all know about spectrophotometry. We're all aware of how infrared and red works and how we get the value. But basically, there are two things. There are two ways of actually sending those light probes, those light sources into the vessel, either transmittance or reflectance. Now, the probes that we use are done by transmittance. Which are the finger probe, the earlobe probe, but we can also use the reflectance probe, which is placed on the forehead, as you can see in this diagram, or this picture, sorry. And studies have actually shown that the reflectance probe detects hypoxia faster than the transmittance probe. It might actually just be because of its position, but it's a bit more accurate. in detecting hypoxia. It's faster. It was faster by about 23 seconds than the transmittance probe. Now, obviously, as we said, you're looking at your trends, but also to ensure that your readings can be trusted, you should also look at your platysmal graph to see that you have a nice clean graph. Remember that there are several things that can give you an unreliable oxygen saturation reading, everything from hypoperfusion, cold clammy extremities, nail polish, a weak pulse. All these things can give you a faulty SAT reading. Also, the SpO2 is supposed to correlate with the SaO2. Now, the SaO2, used from studies, we've seen that up until about a SAS of 90%, it correlates quite well. There's some disparity. And most of our critically ill patients will have an SpO2 lower than 90. So the idea behind that is saying, if you have a patient with an SpO2 of 90, do the blood gas to check the SaO2. Okay. Is everyone still with me? I feel like I'm talking to myself. Okay. Now, it's important to know that. Oh, fantastic. Well, good. So it's good to. The SpO2 is easy. It's not safe. It's quick. You can do it anywhere. And because your value is pretty reliable up until a point, it's something that is very useful in our practice. In fact, I can't imagine what we were doing before the pulse oximeter came to us. Okay, so cardiovascular monitoring. I'm going to slow down a little here because a lot of the things that we do in the ICU is actually cardiovascular monitoring. Hemodynamic monitoring is essential in the ICU, okay? Because we're only alive because we're breathing and our heart is beating. Now, for us to be able to detect changes in the patient, hemodynamic monitoring is essential. And when we think about hemodynamic monitoring, we're thinking about the 4 components, which is preload, afterload, contractility, and the rate. Now we have the rate covered using the ECG, and we've talked about that. So let's talk about preload. So basically, you want to know how well filled your patient is. What's the volume status of your patient? You have a patient comes into the emergency room with a blood pressure of 80/40. So you want to give some fluids, and you want to know you've given fluids, and you want to see the response to that. Sometimes you've given a patient 1.5 liters of your crystalloid, and you haven't seen an appreciable change in the blood pressure. And you want to know how well did that, how much did that, how that do for the patient? Does the patient need more fluids or less? One of the easy things that we could do, apart from, after giving the fluids, checking your blood pressure again, or doing your leg raising to see if the patient responds to that after a fluid bolus, is checking your central venous pressure. Almost every patient in the ICU will get a central line fact. So even though it's invasive, it's not more invasive just to monitor. It's actually useful for other things. So you could check the preload using the central venous pressure monitor. However, it's important to know that what the value you're getting only tells you about the right ventricular filling. It doesn't actually include the left ventricular filling. And for your ventilated patients, the value can't actually be taken at face value because many things affect it. Thoracic pressure affects your central venous pressure monitoring, pericardial pressure, abdominal pressure. So you have a patient with ascites or raised intra-abdominal pressure for whatever reason, portal hypertension. You can't actually take the CVP for what it is. It's not reliable, unfortunately. But people would say, so should we throw it away? No, I don't think so. I think it's still useful, especially for the trends. I think when you see, if you give a fluid bolus and you check your CVP, and check your CVP and it's improved, that, at least that's done something. So it does still help, but it's just unfortunate that it doesn't give you, it's not, it can't be used on its own. You have to use other things. So as with all of the things that we do in ICU, you have to correlate what you're doing with the clinical findings, and all these things have to come together. It's not just one thing. So you connect your transducer to your central line. Remember that your central line has to be in the SVC, so you needed to have confirmed the position of the tip of your catheter to ensure that you're getting the right reading. And then the transducer is connected with the sensor and onto the monitor, and you can see a continuous reading. You could also use a manometer that's connected to a saline drip, but that is even less reliable, and it's not advised, to be honest. Now, okay, so we've said the central venous pressure only tells us about the right ventricular filling. What can tell us about the right and the left ventricular filling, so we have a good idea? Well, we then have to start talking about the Swan Gans catheter. But to be honest, this is very invasive. It is fraught, with complications, infection, trauma. It's not, there's a lot that goes into putting a Swan Gans catheter. And to be honest, I don't know any center in Nigeria that actually does that routinely. But obviously, you get a lot of information from it. The CVP, the pulmonary arterial occlusion pressure, the cardiac output, stroke volume. It tells you a lot. You can even use the values to calculate your oxygen delivery and your VO2, which is very important. But the truth is, not all your patients in the ICU will need this. And even the patients who will need this, there are other less invasive ways of figuring out what's going on with the patient. And also with your pulmonary arterial catheter, it's not actually going to give you a continuous reading because you have to keep recalibrating and things. So it's a lot more hassle than you'd like. So this is an image.
Dr. Peters, you have less than 10 minutes.
Okay, so catheter goes in. It's in the pulmonary artery. It has lots of advantages, but lots of disadvantages. So we can't. But there are other methods that we can use. We can see you have the TrueComs that actually leaves a device within the catheter, and you can attach it and then continuously monitor all the values. And then you can use your pulse contour analysis method in combination with your transpulmonary thermodilution method, like the Pico or the LIDCO. And those also give you a host of values that are very useful. And you can also do your echocardiogram, either a transthoracic one or esophageal, where you have that technology. Just a quick word about the Pico studies. Using different studies have shown, initially when it first came out, people were wondering, are these just random number generators or do they work? But studies have actually shown that the parameters that we derive actually can help to shorten length of stay in the ICU and shorten mechanical ventilator days. But unfortunately, comparing all of them to using your Swan Gans catheter doesn't really show any added advantage, to be honest. So these are the host of things, but I just want to mention this right here. See this extravascular lung water? It's very important because sometimes you don't want to get to the point where you're filling the patient so much that you now tip them into pulmonary edema. And figuring out the extravascular lung water as well as the pulmonary vascular permeability index can help you determine at what point you stop fluid resuscitation so you don't drown the patient. Respiratory monitoring, remember respiration is two components, oxygenation and ventilation. We all know how oxygenation goes down. We check for cyanosis, we check the oxygen saturation or the SaO2, but for ventilation, obviously you want to listen to make sure the patient is breathing. And you want to check the end-tidal CO2. Remember, end-tidal CO2 does not correlate to the PaCO2 in your sick patients who have bad lungs and who are being ventilated. So to be honest, in the ICU, it's not a very useful tool, I'll be honest. But the more important thing is your arterial blood gases. As we all know about arterial blood gases, remember that it shows us a wide range of variables. Some of them are obtained and some of them are derived. Now, it monitors our respiration, but a host of other things, PaCO2, PO2, SaO2. Remember to check on your lactate if you have that on your blood gases, because that tells you about tissue oxygenation, and it's an indicator for how well you're resuscitating patients in shock. Please, all centers, do not ventilate patients and sedate and paralyze without checking ABGs. By the time you're looking out for sweating and phoresis to check if your patient is hypercapnic, it may be too late. Neurological monitoring, obviously we all know about monitoring the GCS. We know sedation scores, there's Ramsey, Vadenbrug's, Bloomsbury scales, and we can shine a light to check for pupillary light response. But these things are very subjective. People may get it wrong and write the wrong thing. So video EEG monitoring is important in neuro ICUs, obviously not for all your patients. And intracranial pressure monitoring, you can put in a bolt in the subarachnoid space. But what if the gold standard is actually putting in a sensor into the through the EVD, so you can actually monitor, and you can also let out some CSF if the pressure is too high. Obviously, you can also check the brain tissue oxygenation tension, but that's a lot more tricky to do, and you can't intervene. Okay, nutritional monitoring, please. It's very important to monitor nutrition in the ICU. Nutrition is therapy in the ICU. It's not just something we do. We don't just feed our patients with PAP. We calculate the calories they need. And most importantly, of all the macros, we need to make sure we're giving them enough protein. Suzuki et al. Found that adequate protein intake has been associated with improved 90-day outcomes in the ICU. So we don't want to just be throwing, blenderized diets or fortified PAP without actually knowing what is fortified with and how much protein is the patient getting per day. So we want to make sure we're actually checking and monitoring nutrition in the ICU. So we can do it either by checking blood chemistry, pre-albumin, lipid profile, especially for patients who are being fed parenterally, liver function tests, obviously your blood glucose. You want to make sure you're monitoring your blood urea for patients who are getting a high protein diet, because you want to make sure they're given enough fluid for the urea. Things like monitoring the patient's weight, BMI, skin fold, mid-arm circumference, they're not very useful. As you can imagine, patients can be edematous and they gain weight, and the patient's premorbid state. So it doesn't really tell you a lot. And we used to, beat ourselves over on the head about pre-albumin and albumin to check. But remember that in your critically ill patients, there's a lot of inflammation. So albumin will drop even if you are feeding the patient well. So the truth is that pre-albumin is good to assess your nutrition intervention, but probably doesn't just tell you about the nutritional status of the patient before that. Remember that the skin is the largest organ in the body, so we shouldn't, neglect it. We have to inspect and monitor your patient's skin. You need to make sure that you're looking out for molting, you're checking the temperature, check the toggle, check for color, and this has to be done at least at every shift. Bed sores are a very common cause of death. If it could bring down Superman, it can kill anyone. Remember Christopher Reeves, he didn't die just because he had the accident. What actually ended up killing him were bed sores. So make sure you check. So in summary, I hope I've used my 30 minutes wisely. The important thing I want you to remember is we need to monitor, you need to record, you need to observe the trends. Don't just take an absolute value, observe the trends and then take action. Don't ignore the signs, and your patients will get better. Thank you.
Wow, thank you so much, Dr. Peters. Your time management is on point. That's great. Yeah, you have reminded us today about the fact that if we do not measure appropriately, we cannot manage. That's very key. You also reminded us that monitoring in ICU is an integral part, of critical care, and that trends are more important than a single value. That's very important. Thank you. And you said we should not ignore alarms. Yeah, I know it's so easy to just go there and just, stop making noise and you want to walk away. But it's important, yes, that we shouldn't ignore alarms. Thank you so much. And then you also mentioned parameters that we should measure. Thank you also for mentioning that, you laid emphasis on the importance of monitoring ABG in ventilated patients. That's very key, that we don't just leave them until we wait for, they are sweating, they may be retaining CO2. So that's also very important. So thank you so much for this very, extensive and educative presentation. Please, for the house, questions for Dr. Peters, she will address them at the end of the presentation, at the end of the second presentation. So please feel free to post your questions in the chat box. it will be addressed, after the second presentation. So I would like to invite our president, Professor Elizabeth Nwaso Ogboli Nwaso, the president of the Nigerian Society of Anesthetists, to please introduce our sponsors for today. They have a product, presentation. For our sponsors, they have 10 minutes for their presentation, and questions, for them will be answered immediately after. Another 10 minutes will be answered immediately after their own presentation. So, Ma, you have the floor, Ma. Prof, Ma.
Thank you very much.
Yes,
thank you very much, Dr. Obiseson. Thank you so much, Dr. Peters, for that excellent presentation. Today, we have the pleasure of having as our hosts or our sponsors for today, Komen Komen Scientific Company. They are a company that is based in Shenzhen, China, and they specialize in anesthetic equipment, monitoring equipment. Hello, can you hear me?
Can hear you, Ma. Yes, ma'am.
Yeah, okay, so they specialize in monitoring equipment and anesthetic equipment. So today they will be given 10 minutes to talk more about themselves. So the best is yet to come. We wait to listen to them as they explain to us who they are and the products that they have to offer. So we'll call them now. Mr. Frank Louis is the representative. With him is Mr. Hosanna. I don't know who is doing the presentation, but one of them will be taking the presentation. So please go on.
Okay. Isabel, Miss Isabel is going to have the presentation. Okay, thank you.
Hi. Okay. First, I need to share my PPT.
Go on, we can hear you.
Okay. Hello, ladies and gentlemen. I'm Isabel, International Marketing Specialist in Komen. Today, I'm very glad to be here to make the presentation about our company, Komen. Wait a moment. Komen is one of the biggest Chinese medical supplier in China. We have started the business with a patient monitor. Hello?
Yeah, go ahead, Sabe.
Yeah, you go ahead, please.
Can you see my PPT?
Yes, continue.
Wait a moment. I need. Okay. Sorry, wait a moment.
We can see your slides, so you can go ahead, please.
Okay.
Yeah.
Today I'm very glad to be here to make the presentation about our company. Komen is one of the biggest Chinese medical supplier in China. We have started the business with the patient monitor in 2002. After 19 years development, Now we have the most comprehensive product line, which is covering almost the whole department in the hospital. Moreover, in 2020, our company reached up 2,000 employees all over the world. Sorry, wait a moment. There is something wrong for my connection.
But we can hear you very well. We can see your slides.
With the rapid development of our company, Common has gradually established its principle all for the end user. To realize this strategy, Common has cooperated with specialists from top-grade hospital in China, achieved collaboration between hospital, research, and business. By now, 40 of our patent is from our cooperation with the hospital experts. In order to ensure the release of the new product and the improvement of product quality, every year, Common invests more than 16 of its annual revenue on the research and development. There are more than 700 research and development specialists, and 65 of them has postgraduate in the biomedical field. After years of research and development, Common has over 840 patents and maintain an annual increment of 30 to 50. Common has started the international business since 10 years. We have obtained the certificate including ISO, CE, CFDA, and FDA, and so on. Back in 2018, Common spent $5 million to upgrade the experimental testing center, which is one of the only 2 experimental testing laboratories in China. The testing center can satisfy the testing requirements of EMC and the safety regulation. By the effort during the last 19 years, now Common's products are covering more than 90,000 medical institutions, 70% of top hospitals in China. Common has also expanded the business around the world. Now we have 33 subsidiaries in total, and 60 of them are overseas. We have provided medical products and service over 150 countries. Based on the clinical demands, we provide medical instruments in 3 different product lines. The first is the most comprehensive monitor initiated by specialized product-specific usage. The second one is comprehensive NICU solution. The third one is comprehensive OR and ICU solution. Later, I will introduce the 3 comprehensive solutions and its benefit one by one. Firstly, is our patient monitoring line. As the world's first advocate of specialized product-specific usage, Common has developed a specialized monitor that meet different clinical needs. Also, patient monitor can be interconnected with the central monitoring system and the hospital information system. Common is also one of the only 2 manufacturers in Chinese market that can provide a comprehensive OR solution. We can not only provide the anesthesia workstation, operating table, and operating lights and other equipment, but also provide an intelligent operating room management system. We call it Smart OR system. Common is also one of 2 manufacturers on the Chinese market that can provide a comprehensive ICU solution. We can provide a ventilator, infusion pump, HFNC, defibrillator, more than 10 kinds of products. Apart from our comprehensive solution for OR and ICU, we also provide a professional NICU solution. Common is the first one who provides the most comprehensive digital NICU solution compared with its worldwide competitor. We can provide up to 10 kinds of products for the medical care of neonate for after 10 years development, like the incubator, radiant warmer, neonatal ventilator for the respiratory support. In the next part, I would like to show you our reference hospital information all the world. In China, over 70% of top-ranked hospitals use our product. We also have innumerable international reference hospitals in Paris, in Italy, in Sweden. Our ICU product have been highly recognized. This is our NICU reference hospital in Southeast Asia. Next, I would like to share our commercial strategy. Every year, Common launch 5 to 10 new products to keep our competitiveness in the market. Today, we are really excited to hear the wonderful presentation from the doctors. For the anesthesia machine, Common can provide 8 models anesthesia machine from low-end market to high-end market to satisfy the different clinical needs of the anesthesiologists. This year, Common launched the latest high-end case series. This is our case series. The high-end case series is designed for critical care monitoring because it provides advanced parameter like Massimo Rainbow Set module, RSO2 module, and so on. It also integrated multi-clinical assistive application to improve doctors' diagnostic efficiency. It could also achieve data transmission by our transportation module and be connected with our other ICU device and the hospital information system to realize all-round monitoring of critical patients. This is our respiratory product line, defibrillator family, new infusion product line. Apart from providing and sharing cutting-edge technology and high-quality products with the world, Common is also willing to organize and participate in public welfare activities. Common is the producer of 2 public welfare documentaries. Those 2 documentaries are very appreciated by the medical staff. We are also really looking forward to shooting similar documentaries with all of you doctors here in Nigeria. Common is also willing to take its social responsibility by donating medical instruments and materials to the victims who are suffering disaster. Inspired by the spirit of innovation and striving and sharing, Common will always keep moving on with our partners and share the benefit with the world. Okay, this is a brief introduction about our company. Thanks for your listening. Finally, I would like to show you a small video about our new showroom.
Thank you. How long is the video, please? Hello?
Hello. Wait a moment.
How long is the video? Thank you. How long is the video, please? All right, thank you so much, Komen, for...
Thanks for your listening.
Okay, thank you so much for your product presentation. We appreciate you.
Thank you for your listening.
Okay.
Is there any question about the presentation or our company? We are open for serious questions.
Okay. No question is posted in the chat box yet. But please, if anyone wants to ask questions, we can unmute you to ask your question verbally. Because I can see there's no question. Okay. All right. There's a question here that says we need your Nigerian contacts. So please.
If you have the other question about our company or the presentation, please do not hesitate to contact our sales team. This is our sales team's contact.
Okay, you don't have a contact in Nigeria?
No, I'm trying to set my email address right now. I'm typing it already.
Okay.
Okay, thank you.
All right, thank you very much. So please, you can post that contact on the chat box. Okay. So any other question? I can't see any hand raised, and no question also in the chat box.
Don't worry about that. We also have local employees in the local market. So if you have any question, you can leave your question by the email or contact with our local employees.
All right. Thank you very much for your presentation.
Thank you. Okay. Thank you so much.
All right. So thank you. We move on to the next lecture. Hello. Okay. We move on to the next lecture. Our next speaker for today is Dr. Adekunbi Oshopindo. She trained at the Lagos State University Teaching Hospital. She obtained FWASC in 2021, and presently she is a consultant anesthetist in the same institution where she trained, in Lasut. She has special interest in neuro anesthesia and intensive care. So Dr. Adekunbi, hello, you can start your slide. You can start sharing your slide. You have 40 minutes, please.
Okay, thank you very much, ma'am.
Yeah.
Good evening, consultants, my teachers. Good evening, senior residents and residents all present on the forum this evening. I'm going to be talking about anesthesia for the polytraumatized patients. As I said before, I trained in Lasut, and I also want to use this opportunity to thank my teachers, both in Lasut and different institutions. Thank you for bringing out a good product. I'm going to be talking about this topic under the following outlines: introduction, problems associated with trauma, primary survey, secondary survey, talking about case scenarios in our environment, anesthetic management of this patient, special considerations, the conclusion, and my references. As an introduction, trauma is the leading cause of death in young people in the world and the third most common cause of death in all age groups. Most forms of trauma are due to road traffic accidents. Other causes are insurgency, like we had in our NSAS problem last year. Sometimes fire outbreaks, even fights and burns also. They are causes of polytrauma in our environment. Polytrauma can be defined as a clinical state following injury to the body, leading to profound physiometabolic changes involving multiple systems, or can be said to be patient with any one of the combination of the following: two major system injury with one limb injury, one major system injury with two major limb injury, one major system injury with one open grade 3 skeletal injury, and unstable pelvic fracture with associated visceral injury. In ideal situations, patients start treatment first of all at the scene of the trauma. They are treated by ambulance service personnel, paramedics, and transported to secondary or tertiary institutions for proper management. However, this occurs in the reverse in our environment. Patients are not properly transported. They are moved by Okada, Keke Marwa, just passerbys. Sometimes they're just even thrown in the trucks of police vans and road safety officials and brought to the hospital just like that. Polytraumatized patients require multiple disciplines in their management: the neurosurgeon, the plastic, the anesthetist, the physiotherapy, the nurses, the blood bank. They require almost all the aspects of the hospital in their proper management for proper outcome and to rehabilitation of these patients. And it's been said that 50% of patients that have polytrauma actually don't get to the hospital. They die at the scene of the trauma. 30% more when they arrive on the hospital die, and even 20% of those that live always have chronic disabilities that they live with for the rest of their lives. Now, for the patient to have optimal management, as I mentioned earlier, multidisciplinary management that is time-based and coordinated must occur for a successful outcome in this patient. And as anesthetists, our responsibility starts from even before the patient gets to the hospital. At the site of the trauma, being able to maintain the airway of this patient, providing pain control for them, in the emergency room, being part of the emergency trauma team, being able to even sedate them, be able to go for various procedures to be able to have definitive management, being able to provide anesthesia for this patient in the OR, and also post-operative care of this patient, either in the high dependency unit or the intensive care unit, and also transportation of this patient, whether through ambulances or air transport of this patient, or definitive care in other institutions. Now, there are many problems associated with patients that are polytraumatized. They have multiple injuries. The airway, the breathing, and the circulation is compromised. There's limited time for preparation to deal with their conditions. There's inadequate time to be able to get history. Many of these patients present comatose, combative, breathless, restless. So there's even no time for you to get an history for them. There's a risk of aspiration, especially with decreased consciousness in them. Of course, there's potential for difficult airway, especially those that have aspirated prior to getting to the hospital, trauma to the face, trauma to the neck, C-spine injury, which is common in these patients, depending on the mechanism of the injury. And also, they are prone to multi-organ failure, and the most profound one, which is coagulopathy, that occurs sometimes as early as within 30 minutes of this trauma, even before they present to the hospital at all. Now, I'm talking about the trauma life support. It's a system of ways by which these patients are resuscitated to be able to reduce mortality and morbidity in them. It involves the primary survey, resuscitation, secondary survey, and definitive care in the management of these patients. Now, this is just a pictorial depiction of showing the trauma system. When they get to the hospital, we can see that there's usually a certified organized trauma team, which is made up of different aspects: the orthopedic surgeon, the anesthetists, the paramedicals, everybody knowing what their roles are and working effectively to be able to produce the best outcome in these patients. Now, talking about the primary survey, remembering our ABCs of resuscitation. Now, the first thing is talking about the airway in this patient with cervical spine control. Otherwise proven, it said that any patient with any form of trauma, whether burns or not, or even normal trauma due to motor vehicle accident, that cervical spine injury should be ruled out until otherwise proven. And sometimes these patients don't even have symptoms immediately, they are delayed. So therefore, in being able to intubate these patients, you must always have manual inline stabilization done in them for the airway to be patent. And also even simple procedures like chin lift, jaw thrust, passing of the nasopharyngeal and oropharyngeal airway at this point can help in making the airway patent in these patients. Now, breathing and ventilation of these patients, it's important. Some of them can present cyanosis, breathlessness, which are things that can occur in, which are symptoms that can be that can occur in patients that have rib fractures, pneumothorax, also those that have cardiac tamponade in them. All these are things you have to look out for and see what can be done for this patient at this point in time prior to definitive management. The most important thing in this patient is resuscitation, which involves the circulation. The primary survey also goes hand in hand with resuscitation ongoing. Now, for resuscitation of this patient, definitely the mainstay is giving of blood and blood products. But in our environment where we don't have blood products readily available, we start with our crystalloids, usually our 0.9% normal saline. For circulation to be properly sustained in this patient, there's what we call the damage control resuscitation, which is between 1 for 1 for 1. That means that for 1 pint of blood given to this patient, a pint of fresh frozen plasma should also be given, and also a pint of platelets also should be given. Now, for maintenance of circulation also, these patients sometimes they require what we call the damage control surgery. This is a life-saving surgery that is done in patients that have major hemorrhage, for instance, those that have their legs auto amputation, they have open injuries, femoral fractures with open injuries that may require amputation. And in the new wave that is occurs now, sometimes in the other climes, interventional radiology can be done to embolize such vessels to be able to even still preserve the limbs in some cases. The reason why they do damage control resuscitation is the fact, as I explained before, is that it has been found that even as early as within 30 minutes of this trauma, some of the patients can have what we call the trauma-induced coagulopathy. But it has been found that if the damage control resuscitation can be instituted in time and blood products given using the one-to-one rule, this reduces the risk of trauma-induced coagulopathy in this patient. Now, disability also is looked out for, looking especially for neurological disability, looking at any case, any history of tenderness, any of the limbs, paresthesia also in these patients. Then exposure, you want to expose the patient all around and see if there are any lacerations or any external wounds that can be quickly picked and sutured to prevent further hemorrhage in this group of patients. Now, talking about the airway can be obstructed, which occurs most times in patients that are polytraumatized, especially when they have damage to the face. Also, sometimes patients with head injury, patients with basal skull fracture, they can even have trauma to the mouth, and this can lead to blood in the mouth, and sometimes there's aspiration of gastric content, foreign body, dentures. This cannot sometimes be picked because these patients are just rushed into the emergency room. No history can be taken from them. But if they are picked, we should just remove the obstruction. Always never let us forget that the most important or most common thing that causes airway obstruction in this patient is the lung. And simple procedures such as chin lift and jaw thrust can help to just maintain the airway in them. Oxygen therapy in this patient must always be 100%, and always aim to make sure that you give adequate oxygenation in them. As I mentioned earlier, manual inline stabilization must be done to prevent further C-spine injury. And sometimes these patients, because of polytrauma to the face, they might require front of neck access, that is the tracheostomy or the cricothyroidotomy in them, to be able to give them adequate oxygen and to be able to make sure that hypoxia is not occurring in this group of patients. Now, talking about the breathing, when you look at this patient, is the patient breathing normally? Look at the respiratory rate. You look, feel, and listen. Is the trachea deviated or not in this patient? Is there air entry? How is the percussion note of this patient? You want to look at all these factors. Looking at all these life-threatening injuries, these are the things that can increase or cause fast mortality and morbidity in these patients. Tension in pneumothorax in them. Some of them don't even get to the hospital with all this. And when they get to the hospital, how easily or how fast is it picked also? Open chest injury, massive pneumothorax, cardiac tamponade. These are the things that can prevent or impair breathing and ventilation in this group of patients. Now, shock in polytraumatized patients is usually hypovolemic until proven otherwise. Sometimes they can present with neurogenic shock. Sometimes they can also present with cardiogenic shock. And priority for patients is to stop bleeding and replace intravascular volume. Now, ideally, all patients, once a patient has been identified as a trauma patient or polytraumatized patients, they are supposed to have what we call a transfusion pack. The transfusion pack consists of 6 units of packed cells, 2 units of fresh frozen plasma, 1 platelet, and 2 cryoprecipitate. However, this doesn't occur in our environment. Also, the crystalloids in use in resuscitation of this patient, first of all, you want to start at 1 to 2 liters fast for this patient to be able to maintain the blood pressure, also to make sure that the pulse rate is not too high in them. Then also, there are different schools of thought, although being able to resuscitate depends on the amount of hemorrhage that has occurred or the level of hemorrhage or class of hemorrhage that occurred in this patient. Also, therefore, you want to still do your damage control resuscitation, your damage control surgery, and importantly, prevent a trauma-induced coagulopathy. This is a very important predictor of increased organ impairments, infection, and death in this patient. Recently, it's been said that giving 1 gram of tranexamic acid within 8 hours of the onset of the trauma has been found to impair or reduce the incidence of trauma-induced coagulopathy in this patient. And sometimes they may require inotropic support, even prior to definitive management of this patient. Now, talking about the class of hemorrhage, this will determine how much resuscitation, how much fluid, how much blood that needs to be given to this patient. Class 1, blood loss up to about 750 mils. The class 2, 750 to 1,500 mils. The class 3, 1,500 to 2,000 mils. And the class 4, greater than 2,000 mils of the blood volume loss. Now, this is just an algorithm showing the management of patients that are polytraumatized, how they are managed. Looking at it, looking at this algorithm, we can see that resuscitation serves as a bedrock of this patient. There must be resuscitation of this patient at each point in time. And looking at it, you want to start your primary survey, taking history if it's possible for patients. You want to make sure that patient is stabilized. Looking at it, whether a damage control surgery may be needed for this patient, moving to the operating room, and sometimes even after the primary survey, may require moving straight to the intensive care unit. To all the physiological factors are stable enough for the patient to have surgery if need be in this kind of patients. Now, in being able to resuscitate this patient, there must be an endpoint and a goal of what you are trying to achieve. You don't just start giving fluid and just saying, oh, I want to just give fluid and give it. You must also remember the fact that there's a risk of overload, and there's also risk of massive blood transfusion when you give too much blood in this patient. So our goals of resuscitation include systolic blood pressure of 8 millimeters of mercury. You want to make sure the heart rate is less than 120 beats per minute. You want beats per minute, you want to make sure the saturation of oxygen is greater than 95%, urine output of 0.5 mils per kg per hour. At least the patient is alert, is able to obey command. You want to make sure the saturation has come up, this Glasgow Coma scale has come up. A patient that was not responsive or lethargic is able to respond. You want to make sure the lactate level is less than 5 millimoles per liter. Then hemoglobin, maintaining it greater than 7 grams per dl, and pH greater than 7.2.5. Remember that these patients that they have what we call 3 lethal factors that makes them have increased risk of mortality and morbidity in them, including acidosis, hypothermia, and coagulopathy. These 3 factors, if they come into play in these patients, then there's the increased risk of mortality and morbidity in them. Talking about the secondary survey, you want to first of all take ample history. You want to take allergies, history of allergy, any allergy in them, if they are able to give you that. Medications, past medical history, last meal, and also intent that led to the trauma in this patient. In this secondary survey, a thorough assessment must be done of the neurological, respiratory, and cardiovascular system. You want to look at all the cranial nerves, any neurological deficits. You want to check the chest. Is the patient being able to breathe at that point in time? The cardiovascular system, is this hypotensive? Has hemorrhage been secured in this patient and there's no more other blood loss? Then you want to conduct what we call the focus assessment sonography in trauma for this patient. This is just a bedside form of ultrasound that is given to patients, especially when they are unstable and they cannot be moved around. This helps to focus on the chest and the abdomen. It helps to rule out whether there is fluid or blood in the chest or in the abdomen. Also, the CT scan, especially patients that are unconscious, X-rays of the extremities, if there is swelling, to rule out any fractures in them. Sometimes surgery has to be delayed in this patient, as I said before, to be able to make sure that their physiological status is balanced or ascertained before they can move ahead to have surgery. Then sometimes initially patients might require ICU or HDU admission. Usually, this secondary survey should have been carried out within 12 to 24 hours after injury, but that doesn't occur in our environment. Now, there are different scoring systems used in the assessment of polytraumatized patients. The Glasgow scale that is used most times for head injured patients, divided into either mild, moderate, or severe. The mild will involves a Glasgow Coma scale of 13 to 15, the moderate of Glasgow Coma scale of 9 to 12, while the severe is a Glasgow Coma scale of 3 to 8. Now, the abbreviated injury scale, the injury severity scale, new injury severity scale, they talk about mortality, morbidity, and also talking about the length of hospital stay. These are used most times in the orthopedics, and it involves classifying of either the head, the face, the neck, the thorax, the abdomen, the spine, the upper extremity, and the lower extremity, and also external environment or external parts of the body in this patient. Now, it can be divided either to say whether there is mild, moderate, severe, or serious, or critical, or patients cannot survive at all. This scoring system just helps to be able to triage the patient and know those that require resuscitation and those that know that they are stable enough already. Now, I'm going to be talking about two case scenarios showing our drawbacks in our environment or when we have polytraumatized patients, how we manage them, despite the fact that we are low income, so to say, we don't have enough things to be able to carry out the best outcome of these patients. Sometimes we have good outcome, but sometimes we cannot just help it. So the first patient is a 24-year-old man who was involved in a motor vehicle accident. He presented with loss of consciousness with a GCS of 3/15, multiple lacerations, and left leg swelling. An assessment of severe traumatic brain injury was made and query left tibia fracture. The patient the consult was gotten in from the emergency room, and so therefore patient was transferred to ICU. He had a cervical collar already, but he was intubated using manual inline stabilization, and it was ventilated on the continuous mandatory ventilatory mode. Our initial FiO2 was 1, and en route on the way to the ICU, he had the brain CT scan, he had a chest X-ray, and X-ray of the lower limbs was also done. On admission into the ICU, his initial vital signs was blood pressure of 96/52 millimeter of mercury, pulse rate was 107 beats. The saturation of oxygen was between 90 to 92. This was all before intubation. In ICU, the food blood counts, electrolyte, urea, and creatinine were ordered for, and ABG was done. Then also blood was grouped and cross-matched in this patient. As all this was going on, simultaneous resuscitation was commenced. He already had a peripheral line, so fluid was started, normal saline was given. Then also a subclavian central line was passed, and consults was sent to both the neurological and orthopedic units. 2 hours after admission, patient was reassessed again. The blood pressure had come up to 100/57 millimeter of mercury. The pulse rate had reduced to 102 beats per minute. The saturation of oxygen had increased to 98 to 100%. IFPCV showed a value of 26%. 24 hours after his admission into ICU, a CT report showed a non-operable traumatic brain injury, and he had also a left tibial fracture. Now, the orthopedic unit came back to review him, and they had a decision that the ORIF should be done on the patient. Patient was already intubated, so he was just intubated and ventilated and moved to the OR. He already had 4 pints of blood and 2 fresh frozen plasma grouped and cross-matched already. Monitors were attached, the standard monitors, and it was connected to the circle system. It was maintained on isoflurane and oxygen. Fentanyl and paracetamol was used as analgesic. It was paralyzed with purpurina. He was transfused with 2 pints of blood and 1 fresh frozen plasma intraoperatively, and surgery lasted 2 hours, 45 minutes. There was no critical incident intraoperatively. After surgery, patient was still intubated. He was transferred back to the intensive care unit. He had a tracheostomy done on day 10. He was weaned off mechanical ventilation on day 27, and he was discharged from the ICU on day 31. It was found that 10 days after discharge from the ICU, he was discharged home finally. However, the second case is a middle-aged unknown man who was rushed into the OR, gasping. He was a victim of gunshot to the upper limb and abdomen. There was obvious intestinal evisceration, and his dress was soaked with blood. There was no history to be gotten, no family members. Surgeon just brought him, scooped him to the theater and brought only 1 pint of blood. However, blood bank was already informed and they were grouping and cross-matching 2 more pints of blood. Patient was restless, pulse was feeble, and initial blood pressure was not recordable. The monitors were attached and peripheral veins were not accessible. A jugular access was gotten using a 16G cannula. The 0.9% normal saline was commenced. Patient was intubated with just only ketamine 50 milligram and connected to oxygen. Was maintained using bolus of ketamine, intermittent bolus of 15 to 20 milligram every 15 to 20 minutes. The only blood available was transfused. 2 more pints of blood was brought intraoperatively, and this was also given to the patient. No blood product was available. Of course, inotropic support was commenced. Adrenaline was available. No adrenaline was also commenced. Surgery lasted 1 hour, 7 minutes. The post-op vitals were blood pressure of 85/42 millimeter of mercury. His pulse rate was 125 beats per minute. The saturation of oxygen was 97%. He was transferred to ICU, intubated and ventilated. However, 12 hours into admission into ICU, he developed a cardiac arrest and there was no return of spontaneous circulation. That's the dilemma we face in our environment. Having patients, sometimes you don't know what to do. But ideally, these are the things we need to do. Talking about the anesthetic considerations of this patient. Now, the analgesia and sedation for diagnostic procedures prior to even whether they decide to have surgery or not. It serves as a problem because you don't know which drug that you can use for this patient that will further cause hemodynamic instability of this patient. Then also they are in pain, they are combative. How are you going to be able to do the proper, give some proper sedation to such patients? Pre-operative evaluation and resuscitation. Many times they come to the hospital just identified as unknown. Hemodynamic management, grouping and cross-matching. Do we have blood and blood products available? Is it always readily available? The anesthetic management of these patients. Patients, however, should be always individualized. General anesthesia, regional or peripheral nerve block. Which one do you want to perform? Depending on the presentation of this patient, definitely. Then post-operatively, some of them may require critical care management. The management of these patients also. Remembering, critical care is expensive in our country and most patients pay out of their pockets. The chronic pain that follows them also, rehabilitation back into the society, back into their working place. These are all challenges to us as anesthetists because they come back to us with chronic pain syndrome, neuropathic pain. Anesthesia in these patients could be challenging because of the fact that we have limited history, because of their comorbidities, medications, allergies. These patients can present to us hemodynamically unstable and they are not properly resuscitated, and damage control surgery must be done. Occult injuries which have not been picked on examinations also can be in this patient. Airway injuries, which makes being able to maintain the airway, even intubation in them, difficult. The limited time for optimization of comorbidities, that's even if it has been picked or even known in patients that can give history appropriately. Now, anesthetic evaluation of this patient starts from our history as much as can be gotten from them. A thorough airway assessment because they are what we call potential difficult intubation. Physical examination also must be done. Evaluate the airway, breathing and circulation. Look if there are other injuries involving these systems. The mental state, the focal neurological sign. So also this level of consciousness, any cranial nerve deficit, focal neurological deficit, all findings of all the systems must be documented. A thorough pre-operative evaluation of our investigations must be done if patient has been resuscitated adequately enough. Full blood count, electrolyte and creatinine, chest X-ray, lateral X-ray of the cervical spine to rule out C-spine injury. You want to do electrocardiogram, focused abdominal ultrasound, and a coagulation profile. Of course, blood grouping and cross-matching for blood and blood products. Now, there are some things that need to be done in the oral, before the oral can be used for these patients. We want to warm the oral to 26 to 28 degrees centigrade before moving the patient to the theater. The ideal, according to NICE guidelines, the ideal temperature of the theater should be about 21 degrees centigrade. But remember what I said about the lethal triad, hypothermia, the coagulability and acidosis in this patient that makes them increased predictors of mortality and morbidity. We want to avoid it in this patient. We want to ensure there's adequate fluids, colloid and crystalloid. Although colloids are avoided as much as possible in these patients and prefer blood and blood products because, as we said, that colloids tend to increase their risk for the coagulopathy in them. There are fluid warmers, rapid infusion sets, drugs including vasopressors and tropes, blood and blood products, cell saver, forced air warmer, difficult airway cuts, emergency drugs. The patient should also definitely be transported to the theater with supplemental oxygen and monitors attached to them, with the neck stabilized with either a neck collar or a head harness to make sure that the head is not moving around anyhow. Now, in the OR, patients must have 2 wide-bore intravenous access with at least 2 14G cannulas. There must be standard, the American Society of Anesthetics monitors. Remember, now monitors the ECG, the pulse oximetry, non-invasive blood pressure, capnography, core temperature, and also the anesthetist present. Urine output must be monitored also. Then in patients that are unstable, that require surgery as fast as possible, invasive blood pressure monitoring must be done. Non-invasive cardiac output monitor, central venous access must be done in all these patients. Then it has been advocated for because of the fact that they are prone to coagulopathy and also the fact that they receive a lot of blood and blood products which can make them worsen. So they must have continuous point of care coagulation monitors, which include the thromboelastogram and the rotational thromboelastogram. For this patient, you want to make sure you maintain the platelets greater than 100, the prothrombin time less than 15 seconds, also the fibrin greater than 100, also in them. Now, looking at the anesthetic technique of this patient, each patient is individualized. For instance, you are thinking the patient is stable. He has he has a fracture of the upper limb and the lower limb. The upper limb fracture doesn't require surgery. The lower limb fracture requires surgery. Definitely, you want to pick a neuroaxial block for this kind of patient. A patient with gunshots to the abdomen, you require a general anesthesia in this patient. So every patient is individualized, looking at the type of surgery that was to be done, the duration of surgery, and also the hemodynamic status, and whether there's full stomach or not in these patients. Now, this is just the OR preparation as surgery is being prepared for. We can see that sometimes using the CM, ongoing investigations are also carried out in these patients. What I want us to notice is the fact that in the OR, everybody is spaced, carrying out their own designated work. Not that one person is at the airway providing critical pressure, one person is ventilating, one person is withdrawing drugs, and all this, everybody is trying, and another person is trying to operate the CM. Then look, which is very important, there's somebody that is designated that is documenting what is going on, documenting the drugs and at each point in time. These are all important in the management of these patients. Now, if general anesthesia has to be carried out for this patient, we should always anticipate difficult intubation and prepare for surgical airway, fiber optic intubation, and intubation by manual inline stabilization. Now, the fact that patients can move all limbs of their body doesn't rule out C-spine injury. It has been said that there are what we call non-radiology C-spine injury that can still occur in these patients. So these patients should still all have manual inline stabilization, adequate monitoring of our pulse rate, the ECG, the saturation of oxygen, the non-invasive blood pressure, temperature, capnography, and urine output. The recommended fluid in this patient are usually 0.9%, and some say Ringer's lactate. However, it has been said that Ringer's lactate, because of the fact that it contains some form of lactate, can make it, when EEG is done, can mimic a form of acidosis in these patients. So most times, people still prefer to give 0.9% normal saline. Patients must be pre-oxygenated, and intubation should be by rapid sequence induction. Now, there are many controversies about drugs that I should use. And again, I say patients should be individualized and looking at the hemodynamic state of the patient. Now, the choice of induction agents for these patients, most times, especially those that are injured, is propofol. Thiopentone was used initially in the, previously, but we prefer propofol now because of the fact that it helps to maintain cerebral blood flow in this patient. However, because of this patient that they are hemodynamically unstable, propofol makes them prone to hypotension. So therefore, it is being said that you want to give according to effect, you titrate to effect when you are giving the propofol, and sometimes as low as 80% of the actual dose of this patient is what is given to them. And it can be given in conjunction with ketamine, especially when they have what we call the ketal 4 already prepared mixture in these patients. Ketamine also is said to be useful in any drug patient. Initially, it was advocated that you should not be using them because it causes an increase in intracranial pressure in them. However, it has been said that in patients that are hemodynamically unstable, patients that are LD, ketamine has been found to maintain and preserve cerebral blood flow. So it has been advocated that using ketamine in conjunction with propofol can be used in patients that are head injured, and also it can be used in patients that are hypotensive also. The drug that is advocated more for hemodynamically unstable patients is etomidate. Although there's a problem of adrenocortical suppression in them, but it has been said that if a dose of 0.2 milligram per kg is given and it's a single dose that is used, then there is reduced risk of the adrenocortical suppression in them. Also, the myoclonic jerks that occur in these patients, especially patients that are head injured, mimicking seizures in them, this can be mitigated when we give suxametonium in these patients. Now, intubation, as I said, should be by rapid sequence induction, using our suxametonium or rocuronium if it's available. But the problem with rocuronium is that it has a long duration of action, and sugar maltodextrin is required to reverse it. We don't have it in our environment. Now, talking about the muscle relaxants is a controversial aspect also again. However, you must always avoid atracurium and mivacurium in this patient because it releases histamine and further causes hypotension in this patient. If you think the surgery is going to be long, you can use pancuronium in this patient. If percuronium is available because it's cardiostable, it is preferred to be used in this patient. And in all these patients, there must be continuous assessment of their hemodynamic status at each point in time. The analgesic recommended for these patients are ketamine, the opioids. Fentanyl has been advocated for more in them, although it causes hypertension. That is why when we are giving all these drugs, remember, as I said, all patients must be individualized. The NSAIDs, in the patient that are thinking of coagulopathy, you cannot give NSAIDs. It should be avoided in them. Dexmedetomidine, this also causes hypotension, so it is it's avoided as much as possible in patients that are not stable. A new drug that is still under trial is, although it is more used for trauma patients in the emergency room, is methoxyflurane, although it's still under trial, but said that it still is used once in a while in the US. Now, the decision to extubate the patient depends on the factors postoperatively that you see. And also, we should always know that whether this patient postoperatively will go to ICU or HDU or PACO depends on when you assess the patient and depending on the factors you see postoperatively. This is just a way showing how intubation is done in this patient. We can see that to be able to intubate this patient, we need about 4 people. One person does the manual inline stabilization, somebody is ventilating, one person is giving the precoid pressure, and the last person is giving the drugs, all done simultaneously. Now, the criteria for extubation for these patients can be either the respiratory function, the system stability, airway and anatomical reflex, and mental status. The mental status, if this patient is alert and conscious, non-combative, is able to follow commands, then pain is adequately controlled. The respiratory function is tidal volume adequate, and the respiratory rate, patient is not in any form of labored breathing, and it has at least quiet respiration. Then it requires the FiO2 of oxygen less than 0.5. Looking at the anatomy, is the cough and gag reflex, is it adequate? No obvious airway edema, no previous history of aspiration. Then is the patient adequately resuscitated? Is this patient not hypotensive at all? Then is temperature well maintained? Then those are the things you must look at to say, okay, then this patient is at a criteria for extubation. Now, we're able to weigh the pros and the cons of each type of anesthesia that wants to be used in these patients. Looking at general anesthesia, looking at it has a fast speed of onset, can be maintained as long as possible. Sometimes trauma cases, the surgeon tells you it's going to be 1 hour, they end up spending 6 hours, 8 hours. Multiple procedures for multiple injuries. When you see multiple gunshots in different parts of the body to the patient, this can work for them. Then patients can accept it better. Patients that are unconscious, combative, this is better for them. Also allows ventilation. However, there's impairment of global neurological examination. Then it requires airway instrumentation. Then because of the fact that you have pharmacy, you have a lot of drugs to use. And of course, some of them oppose each other. So hemodynamic management is complex in them, and because they are ventilated, especially in patients that you have not yet been able to do proper assessment, there's increased potential for barotrauma if you are thinking of also a trauma to the chest or the respiratory system. Looking at the neuroaxial blocks also, in these patients, the advantages and disadvantages. Looking for the advantages, look at airway instrumentation is avoided. There's decreased blood loss, good analgesia in them, opioid sparing. Then there's less cardiac and pulmonary complications. State physiotherapy in these patients reduces stress response that occurs with laryngoscopy in general anesthesia and allows assessment of mental status. Disadvantages is that cannot be used in patients that are hemodynamically unstable, or there's coagulopathy or neurological deficits or elevated intracranial pressure. It requires patient positioning. These are patients that are already in pain. Are they going to be able to sit down properly for you to give your neuralaxial block or stay in the position you require them to be? Peripheral nerve function is difficult to access also after the block. Then it's not suitable for multiple body regions at the same time. Then, as I said, sometimes the surgery may be prolonged than expected, so it can wear off before the conclusion of the surgery. Now, peripheral nerve blocks, this is used most times in other parts of the world in the emergency room to provide analgesia for patients that have fractures, and even for children also, especially when they want to take them for some x-rays. So for advantages, it provides excellent analgesia, of course, no hemodynamic disruption or respiratory depression. There's decreased incidence of post-traumatic pain syndrome, improved surgical outcome in them. Then also disadvantages, again, as I said, of course, need for optimal positioning, special equipment, specialized training in these patients. If there's coagulopathy in patients, it cannot be used. Then, of course, there's a risk of local anesthetic systemic toxicity in them. Now, talking about specialized cases of patients that present with polytrauma, the hand injured patients, 50% of polytraumatized patients have concomitant head injury in them. As I explained before, using the Glasgow Coma scale, they can be divided into mild, moderate, and severe. And the goals of management of traumatic brain injury, apart from the normal management in the ICU, in this patient, prior to transfer, you want to manage the airway because to protect the airway. So they may require definitive airway management like intubation, or they may require a tracheostomy if there's also trauma to the face or concomitant pain. You want to make sure the blood pressure is well sustained because we're able to maintain the cerebral perfusion pressure. So you avoid systolic blood pressure less than 90 millimeter of mercury. I want to make sure the MAP is sustained greater than 70 millimeter of mercury, and avoid drugs that can further increase the ICP. And that's why patients like this may require proper sedation. You require proper sedation in the ICU. Now, many times of recent, we found that many patients, because of the patients that present to us with polytrauma are pregnant women, and can be either in their first trimester, second trimester, or third trimester. Of course, those are in the third trimester at more risk because the uterus is thin walled and is vulnerable to injury at that time. However, they present because of the trauma that caused, it makes them at risk of different things like spontaneous abortion, preterm labor, or premature delivery. In this patient, as I said, that the management of polytraumatized is multidisciplinary. In this patient, they require the obstetrician being involved. And remember that in this case, there are 2 lives at stake. And the gravity uterus many times make it difficult to be able to assess and give proper surgical control. And even when they have pelvic fracture, hemorrhage is difficult to be able to control in them because of the gravity uterus. However, in the management of these patients, most times the first person that's life that has to be saved is the mother. And the best management of a pregnant woman that is in trauma to be able to save both the baby and the mother is rapid resuscitation of the mother. Now, other things that patient can present in respiratory chest injury, they present with flail chest, rib fractures. These are self-limiting, although the problem with this patient is pain. However, the complications that can occur, atelectasis, pneumonia, acute respiratory distress syndrome. So these patients sometimes may require ICU admission. Pneumothorax, this can be either massive or it can be mild. So if it's mild and the patient gets the hospital, if it's picked on examination of this patient, the chest tube also has to be passed. Tension pneumothorax, if it's picked, deviation of the division of the trachea, listen to hyperresonant heart sound.
Hello, Dr. Adekobi, sorry, you have less than 5 minutes?
I'm
like
almost
3 minutes more? Yeah.
Yes, ma'am. Tension pneumothorax. So this patient must be adequately treated. Also, a chest tube has to be passed also for them. Then the diaphragmatic tear, this can be minor or can be major. Major in that we find out that all the old abdominal contents are in the chest. Patients like this has to have damage control surgery immediately. Now, tracheobronchial injury is said to occur when there's persistent hypoxia, persistent cyanosis, persistent hypotension in patients despite adequate resuscitation. And this can occur even within 2.5 cm of the carina in this patient. Therefore, a high index of suspicion must be given to all these patients when they present with different barrage of symptoms, especially breathlessness. Cardiac injury, most times patients with cardiac injury hardly get to the hospital. They die most times at the site of the trauma. However, if they are able to get to the hospital, those that present are those most times cardiac tamponade, pericardial rupture, aortic rupture. Those that with cardiac tamponade, they require pericardial sentences. The cardiothoracic surgeon has to be notified, and appropriate management should be given to them. The aortic rupture, if it is mild and patients get to the hospital, most of these patients are treated as cases of ischemic heart disease. In summary, trauma involves all age groups, and as anesthesiologists, we would encounter trauma patients during our career at one time or the other. Trauma anesthesia is an evolving aspect with rapidly evolving interest in research and education. The anesthetists as perioperative physicians with multiple roles in the management of these patients need to understand resuscitation and apply different techniques to reduce mortality and morbidity in them. So these are my references. Thank you very much for listening.
Thank you so much, Dr. Adekunbi.
Yes, ma'am.
For this extensive and well-educated presentation. Trauma is huge. It's a global health burden. It's the leading cause of death in the young age group. So thank you for reminding us the ATLS principle of resuscitation or managing trauma patients, going from primary survey to secondary survey and definitive management. You've also been able to emphasize the need to adequately resuscitate our patients before anesthetizing them, and that patients should be individualized. You cannot use one blanket for all. So thank you so much. Now it's time for questions and answers. Dr. Peters, hello, is she still with us?
Yes, I am. Hello, yes, I'm still here.
Thank you. So let me see whether we have some questions for you before we move over to Dr. Adekunbi's questions. So, and please, if you have any question also for, if you wish to speak and not type your question. You can also raise your hand. We have the next few minutes to answer questions. You can use the raise hand icon to indicate if you want to ask questions verbally. All right. Okay, so for Dr. Yeah, the questions I have here are for Dr. Adekumbi. I'm yet to see any for Dr. Peters, but hanging in there in case we find questions for you later. So for Dr. Adekumbi, there's a question here that says, okay, sorry, a moment, please. Okay, it says, thank you, Ma, for the presentation. What would be the choice of fluids, bearing in mind that 0.9% of normal saline is capable of causing hyperchloremic acidosis? What will be the safe type of fluid to use? That's the question for you, Dr. Adekumbi. We'll start with you since I can't find any for Dr. Peters for now.
Okay, thank you very much for that question. Also, noting that the complications, I didn't mention it, is electrolyte derangement in these patients with the giving of the fluids in them. And as I said, it's because of what we call the damage control resuscitation. They prefer most times to give blood and blood products. So it's been expected that maximum of 1 to 2 liters of normal saline in them is expected that at that point you are using it for resuscitation, and is not supposed to cause a hyperchloremic acidosis that will be detrimental to that patient. So that is why it is advocated for to use the damage control resuscitation, which is the 1-for-1. That is for 1 pint of blood given, you give 1 pint of fresh frozen plasma and 1 pint of your platelets also in this patient. So you want to avoid use of fluids excessively as much as possible in these patients.
Sorry, Dr.
Right,
can I just add that I think the question was probably asked because, like you said in your presentation, you may not have blood to hand. Not all centers have ONEG blood in their blood banks for such emergencies. When they're doing the fluid resuscitation, many times people will use saline, and he is correct, there can be hyperchloremic acidosis. So it's actually preferable that you use a combination of saline and ringers. Now, evidence has not shown that ringers lactate causes any increase in lactate, because it is not actually lactic acid, it is sodium lactate. So it's not going to convert to lactic acidosis. It's not going to affect it in any way. It's just sodium lactate. So it doesn't actually cause an acidosis as previously suggested by people. So you could use a combination. And obviously, as you're monitoring, you're going to be monitoring your patient's blood gases. Many times you'll see the biochemical markers there and your electrolytes. If you notice your patient is becoming hypernatremic or hyperchloremic, you can change fluids to 4.3 in a fifth, and just, as your resuscitation goes on. This is real-time practice, obviously, that I'm trying to say, because you may not always have blood to hand. And of course, you could use your colloids if you have them to hand as well. But there is no issue with using ringers and causing a lactic acidosis. It doesn't actually happen in practice.
All right, thank you, Dr. Peters, for that contribution. The next question says, what is the minimum time or hours for transferring critical multiply injured patients to advanced center? Still for you, Dr. Adekumbi.
Thank you very much for the question again. When I was talking about it, I talked about the primary survey, the secondary survey. Primary survey starts ideally from the point of trauma. So in our environment, that doesn't start at all until when the patient gets to the hospital. And it's said that patients should not be moved except if they are stable. Now, the timing for being able to transfer to this patient involves the secondary survey, which should be done within 12 to 24 hours of the injury of this patient. But all this also is determined by the physiological status of this patient, as resuscitation being adequate for this patient at the primary site of the trauma. Is patient hemodynamically stable? The vitals, are they also okay in this patient? So those are the things, that determinants that will determine whether the patient should be transferred at all from the primary site of injury or not.
Okay, thank you. There's another question. Does that answer? Okay, the person that asked the question. Okay, there's another question. It says, thanks for your detailed presentation. I want to ask if there's specific difference between a polytraumatized patient and a multiply injured patient. I think that was in one of your slides. But quickly, you want to address that quickly?
Polytraumatized is the multiple injury, the injured patient. It was just definitions, all different types of polytraumatized patients. One that multiple injury, looking at the slides, as I mentioned initially at the beginning, talking about the definition about polytraumatized patient, I said 2 major system injury plus 1 limb injury, 1 major system injury plus 2 major limb injury, or 1 major system injury plus 1 open grade 3 skeletal injury. Those all are different injuries, multiple injuries involving polytrauma to the patient. Hello?
Hello? Okay,
I'm able to answer the person's question with that.
Okay, thank you. I'm trying to scroll to be sure that I'm not missing out any other question. Okay.
Hello.
Hi.
We have some hand raised.
Okay, all right. So let me acknowledge, let's see. Ma, please, if you can see the hands, you can please help me enable them to speak. They can unmute. I can't see the hands.
Okay,
yes,
it's all right.
You can see it, Ma. Thank you.
Dr. Chumaike, you can unmute yourself, please.
Thank you, Dr. Briggs. I want to thank the two presenters for the excellent presentation. I want to thank Dr. Shukridon for that comprehensive presentation. I'm highly impressed. Thank you very much. I want to add to your presentation 1 or 2 comments. When it comes to central line in these patients, I think actually when I saw your case scenario, actually what led me to mention this, because I saw that the first choice for central line was subclavian vein cannulation. Actually, I think it's safer, especially in this part of the world where you cannot easily quickly do a chest X-ray for your patient. More so, we are talking about a patient with polytrauma, possibly there's chest injury. So I think internal jugular vein cannulation should be the first choice, especially in this part of the world. But if you can quickly do a chest X-ray post cannulation, then no problem with your subclavian vein, but just because of the risk of chest injury. Now, the other one is induction of anesthesia. I agree with you, with your drugs and everything, but bear in mind, we should bear in mind that there's a possibility of hemodynamic challenges, especially following induction. So whether you use ketamine or you use propofol, you must be prepared to support the circulation. So we should get ready with suppressors, nootropics, and all drugs that we might need to support the circulation of this patient immediately after intubation. That will be part of our armamentarium, and not just think that I've used ketamine. If you have a patient that has massively mobilized catecholamines, even your ketamine can induce hypotension in this patient. So those are the 2 comments I want to provide. I want to say thank you to the 2 of you for your excellent deliveries. Thank you very much.
Thank you, sir, for your contribution. Okay, Dr. Yewande, you can unmute yourself and ask your question. I can see your hand up. Dr. Yewande Dara.
Yes, Daramola.
Yes, Daramola. All right, thank you.
Good afternoon, ma. Can you hear me, ma? Hello.
Go ahead, please. You can hear you.
Hello, can you hear me?
Yes, please go ahead. We can hear you.
Thank you, Dr. Shupido and Dr. Yes, thank you, Doctors Peters and Oshupido. I just want to ask Dr. Peters that for a patient that is intubated, sedated, and paralyzed, how often does she advise that the ABG, she mentioned ABG being done, which we usually do in the ICU, but how often will she advise that the ABG be done, ma? Thank you. That's my question.
All right, thank you. Dr. Peters?
Hi, Dr. Yetunde. Thank you for your question. That's a very good question, but unfortunately, there is no actual answer to that. Okay, so I'll give you an example. Say you just intubated a patient and you're ventilating the patient, you've sedated and paralyzed. You want to check the effect, and you had done your gases just before you did that. You want to check the response to your therapy, your ventilatory therapy, because you've set up certain parameters and you want to see what that has done. You'd want to do your blood gases, quite shortly after that. So in my practice, for example, that scenario, I'd repeat a blood gas an hour or two later because I want to see the trends. So if I had a patient who was hypercapnic, maybe had a PCO2 of 64, 72, I put the patient on the ventilator, I am attaining a particular minute volume. I want to make sure that minute volume is actually adequate to blow off that CO2 and keep the patient on an even keel. In our facility, normally patients will get a minimum of 3 times a day, ABGs. More critically ill patients will get blood gases more frequently. So you won't find an actual value in any book that says blood gases, 8 hourly. It all depends on your patient, which is why everything is individualized. And the most important monitor is the anesthetist who is in the ICU and the nurse who's standing beside the patient.
All right, ma. Thank you very much, ma. Thank you very much, Dr. Peters. Okay.
Thank you, Dr. Peters. Any more questions? Any more? And I can't see any other hand up raised. Any other? Okay. All right. Dr. Adekumi, thank you very much. I just want to ask you, do you have a 14G cannula in your center? Because I know you put it, on your slide, and I'm thinking.
That's what I said. That's the ideal.
Ideal. Okay. Ideal. All right. Sorry, I missed out that. I didn't get the ideal.
That's why I put
ideal.
Ideal.
All right. All right. That's okay. Then my other question, you said the goal for resuscitation, that's for the systolic blood pressure.
Yes, ma'am.
Our target should be 80 millimeters of mercury.
Greater than 80.
Greater, okay, because in your slide on TBI, traumatic brain injury, you now said not less than 90. So I was going to ask that, is it not better to use mean arterial pressure? Because at 80 is still low. Yes, we do not want to dilute, we don't want to cause a dilution in coagulopathy in our patient. We don't want to give excess fluid, so to say, but you also need to be able to have the blood pressure, to be up to be able to induce.
However, yes, that's true, but there's what we call permissive hypotension in traumatic patients. It said that this should be done initially for them to help to reduce blood loss in them. Also, for the head injured patient, this is done initially because we want to reduce cerebral metabolic rate of oxygenation in them, reducing metabolism in them to enable proper recovery in them. So, because I also was wondering that was low, so that was their reason in the
for 80 and not 90.
No, right. The systolic blood, yes, initially.
Yes, because I was my issue is the 80, but I now saw 90 later on your slide.
Yes, for head injury.
That's okay.
Actually, it was 80 to 100. They put there as a range, 80 to 100 for maintenance of systolic blood pressure. 80 to 100.
All right. Okay, because even for ketamine, you must resuscitate your patient even before giving ketamine.
Yes,
ma'am. We've had cases of patients arresting after ketamine when there's no adequate resuscitation. So it's very important.
Yes, ma'am. Also, the American Trauma Society, however, also advocates that prior to if you decide you want to use ketamine, you can start first of all giving phenylephrine or epinephrine, that's adrenaline, prior to giving the ketamine, although the dose wasn't given. So it's just advocated for that is in trial that helps to reduce.
All right, thank you very much. I think we've had a very smooth presentation. I will hand over to, I don't think we have any other question. So at this point, I would like to hand over to the president of the Nigerian Society of Anesthetists to give us a closing remark. Ma, Prof, over to you, ma. Hello, ma. Hello. Okay, I'd like to call on Dr. Briggs, the Vice President of the Nigerian Society of Anesthetists, to give the closing remark if we're not able to connect with the President. Hello, sorry, let me just check if she's still with us here.
She should be able to talk to us now.
Now, okay, all right, ma, all right, ma.
President, please, you have the floor. Can you please give us the closing remarks? Hello, Professor Bolinwaso, are you still there?
Yes, I'm here, I'm here.
Okay, I have unmuted you, please. Yeah,
okay,
sorry.
Thank you.
You are muted.
Yes, sorry about that.
It's 2053.
You can go ahead, ma.
Can't hear her, please.
Oh, ma, you are still muted?
No, she's not muted.
Okay.
There's a problem with audio.
All right, ma.
Hello?
We can hear you now.
Okay.
Can you hear me now?
Yes, ma.
Okay, let me remove the earpiece. All right, so I was saying that we want to thank the speakers for today, Dr. Peters and Dr. Shumpidan, and also our able moderator for the session. It's been a very lively session. We also want to thank our sponsors, Komen, for the product presentation they have done. They have put in their contact. Mr. Hosanna is their contact in Nigeria, and he has put his phone number and email address in the chat. So you can check in the chat if you're interested. And if you are also interested in any products, we can also supply you the information directly. Myself or the NSA secretary will supply you the information. So they have anesthetic machines, they have monitors and all that, and they are partnering with us to bring these webinars to our members. So the email address is hosanna@szcomen.com, and the phone number is 0701 041 3619. So you can reach him for the products from Komen. We'll also say that these presentations are going to be available to our members in the NSA YouTube channel, so you can check on if you want any of them. So for the announcements, next week is World Congress of Anesthetists. It will be 1st to 5th September. And we are featuring on almost every day of the program. We have shared the program at a glance, and we will share it again. Please join us, those that have been able to get the free registration. And even now, I think registration is still open. You can still register. It's completely virtual, over 400 sessions, over 300 speakers from over 100 countries. So it's an opportunity for you to sit in the comfort of your bedroom or your sitting room or anywhere that is comfortable for you and participate in this first ever virtual conference of the World Federation of Society of Anesthetists. That is the World Congress of Anesthetists. That is the Olympics of anesthesia, because it brings all anesthetists from all over the world. So please, there will be no webinar next week, Saturday. I have a session on Friday, another session on Saturday, and another session on Sunday. So please join us. And then after that, we'll be having the Society of Obstetric Anesthetists of Nigeria annual conference.
That one will be from 10 to 11th of September, exactly 2 weeks time. So please send in your abstracts. Abstract submission will close on the 5th of September. So we just have 1 week to accept abstracts, and it will be shared again on the different channels and on the emails of our members. So you are free to join. You don't have to be a member of the society to present. Once you are an anesthetist, that is all. But we're also looking for new members for the Society of Obstetric Anesthetists of Nigeria. And so please feel free to join us. And the registration fee is 10,000 for residents, 15,000 for consultants, and older senior diplomates. So please join us. We will be taking the next presentation in 2 weeks, 3 weeks time. And after that, we will take one session for exams, and then we will close this series too. So in 3 weeks time, we'll have 2 presentations by I think I have the names somewhere. Let me just check it. Dr. Ife Zwe will be talking about anatomy of the larynx and awareness under anesthesia by Dr. Oluwadun. So please join us. And that session is useful for those doing primary and part 1. Please join us. And we'll also take a revision session for the exams before we close this series 2 of the NSA webinars. So thank you. It's exactly 1 minute to